And Derek Ritz is joining us to talk about the work that he has done with many players with World Health Organization. Derek, welcome. The floor is yours.
Thank you, Elliot. And I'm going to pre-apologize for two reasons. One, the first reason is that I'm Canadian and it's kind of our thing. And the second reason, I'm going to turn my video on too. And the second reason is that this is going to be a quite different focus. So I'm going to be talking about digital health as an infrastructure investment. I'm going to look at what is the meaning of that. If you think of digital health as infrastructure, what does that mean to say that? I'm also going to look at how digital health impacts on health. And I appreciate that that might sound like an obvious thing, but it's not an obvious thing. And then I'm going to say why it is that we as engineers are needed to help make this happen. And this is especially true in low and middle income countries. This slide I don't want to spend a lot of time on. Really just pictorially, I want you to get to sort of take in that the preponderance of the work I've done in the last decade especially has been in low and middle income countries. I was very involved in Canada's domestic efforts sort of from 2005 to 2010 in our national digital health infrastructure projects. But since 2010, most of the work that I've done has been in sub-Saharan Africa, has been in the Middle East and in the Asia Pacific region. And as you might imagine, a lot of that work has been on behalf of WHO or the World Bank or the Asian Development Bank. I've been an advisor for the last 8 years to the US government's PEPFAR program, which is the President's Emergency Plan for AIDS Relief. It's a $7 billion a year program in 57 low and middle income countries, providing HIV care, treatment, and medicines. So I think it's a bit of a different perspective. So what is digital health infrastructure? And I'm going to use a storytelling technique to try to help us all have our aha moment regarding what is digital health infrastructure. So this particular story is about a migrant worker named Ramesh. And the story unfolds in 3 chapters. In chapter 1, Ramesh is feeling unwell. His malaria-like symptoms are noted by a community health worker in the village where he is staying. And as you see, she has a small mobile phone. It is not a smartphone. This is one of the 10-year-old Nokia phones that no self-respecting Canadian teenager would be caught dead with. In chapter 2, following the advice of the community health worker, Ramesh attends at a community clinic, and there he has a rapid diagnostic test for malaria. In chapter 3, based on the results of the RDT, Ramesh goes to a district health center where they have a pharmacy, and there he receives his anti-malarial medicines. Now, in chapter 1, Ramesh's data is saved to an SMS database from the mHealth app that was being used by the community health worker. In chapter 2, his diagnostic test results are saved to an electronic medical records database from the non-government organization that was running that particular clinic in the village. In chapter 3, the information about his medication dispense is saved to a Ministry of Health service, a web-based solution of some sort. And the problem we have is the one that Eric was pointing out, that these data now find themselves in information silos. And that's the problem that digital health infrastructure addresses. Digital health infrastructure is cloud-based service that provides coordinated service delivery, two-way information flow. And the fact that it provides that gives us continuity of Ramesh's care over time and across different sites. I've been involved since its launch in 2012 with an initiative that was actually funded by the PEPFAR organization called OpenHIE. And HIE is an acronym for Health Information Exchange. And OpenHIE is a completely open source, standards-based blueprint that talks about how different information systems can leverage shared repositories, shared assets, using standards-based interfaces. The version 1 of that, which we released in 2013, was based on a set of IHE profiles. IHE is a standards organization. They don't write standards per se. They talk about how portfolios of standards will be used to support interoperability. But the first version of OpenHIE was based on a set of HL7 based specifications. It has since been updated just in the last year to use the FHIR standard. fast health information resources, which is a new and quite modern HL7 specification that is hot these days. What a terrible pun that is. Yeah, fire is hot. So here's a couple of key takeaways. Digital health infrastructure connects disparate health data. That's its job. And to be honest, it's how we do systems engineering across an entire care delivery network. Again, a key takeaway is that the Open HIE is a standards-based, open source, low and middle income country focused data sharing architecture. And I'll be honest, and I say with happiness, it's the basis of the National Digital Health Blueprint in over 30 countries. It's the basis of South Africa's National Digital Health Norms and Standards. I was a primary author of the Philippines' National Digital Health Blueprint, and I'm engaged literally right now in helping Myanmar operationalize Open HIE as their National Digital Health Blueprint. So that sounds all well and good, but how in fact does digital health impact on population health? So this is actually a diagram from when I did my grad school work, and I call it the loopy diagram. It's a little bit busy looking, but let's step through it, and I think it will make sense if we go just piece by piece. So first, a very non-controversial statement, and that is that health interventions yield population health. That makes perfect sense. That's exactly, these are the things that we've come up with, that we've gone through randomized controlled trials. This is our guideline-based care, and that's how we get good outcomes. Here's where I differ a little bit from many of my health informatics colleagues. I know many people say that digital health is a health intervention, and I don't agree with that. Digital health operationalizes the health intervention. It is in fact an industrial engineering intervention. Its job is to improve the efficacy, the efficiency, the effectiveness overall of the health interventions. But we get something super important when we use digital health to support our care delivery. The data that is generated when digital health is supporting the health interventions gives us, we get person-centric transactional data. And if we are leveraging standards, if we're leveraging something like Open HIE, then these standards-based data can be aggregated to generate population-level health metrics. Now, I get to aggregate at whatever level I want. If I aggregate at the person-centric level, that is by definition a longitudinal health record for that subject of care. But I can aggregate at the provider level and use it to drive performance-based financing or other universal health coverage sort of imperatives around social insurance. I can aggregate at the facility level or at the district level or at the national level to generate health system management indicators that are important. Now, the digital health infrastructure itself is feed-forward process control. But I can now leverage these metrics to do feedback control. These population level health metrics can inform changes I might make to the operation of the health infrastructure, the digital health infrastructure. We can also leverage this to change the health interventions themselves. And we did that. The first few years, the first 5 years or so of PEPFAR data from 57 countries was used to inform alterations to the WHO global guidelines for HIV care. It had a huge and important impact. And this is some of the big data analytics that also Eric was talking about. It lights up very cool and important things that we should do. So pictorially, if we think of the care delivery network being supported by digital health infrastructure and the digital health infrastructure operationalizing standard operating procedures, we see that this is a way for us to make systemic guideline-based care. The digital health is a way for us to support care continuity within the care delivery network. With the digital health infrastructure, we can compare the transactional data to what was indicated in the standard operating procedures. And that's actually a pretty big deal, because what we want is for a care delivery network on a systemic basis to be operating in the green zone. If we think of this as a Venn diagram, the blue circle indicates everything that should have been done. The yellow circle indicates everything that we did do. And what we want is to grow the size of the green zone. There's also two important things I want you to note. One, Errors of commission is where there are things in the yellow circle. I did do something that I shouldn't have done. To be honest, our clinicians don't commit errors of commission very often. It is much, much more common that there are errors of omission, something that should have been done that in fact was not done. How often? I don't mean to air the dirty laundry of my home country, but in Canada in 2014, medical errors, preventable medical errors, killed as many as 30,000 Canadians. And arithmetically, that means that about every 17 minutes, a Canadian died of a preventable medical error. On a global basis, this is very stark. There was a report released by the National Institutes of Health, a US organization, in 2018, and it was called Crossing the Global Quality Chasm. And the key takeaway here is that every year between 5.7 and 8.4 million deaths occur, predominantly in low and middle income countries, because of poor quality care, because of completely preventable medical errors. So following through the rest of the diagram, I can generate my population indicators by leveraging the transactional data and aggregating that. And then I can modify the standard operating procedures. And this gives us the ability to do another important engineering task to support continuous quality improvement. And in fact, the National Institutes of Health in the United States has dubbed this the learning health system. The idea that the more times I go through this cycle, I spiral my way to greatness. So digital health investments give us a way to meter the system, and yes, that's important, but it also affords us a way to exert process control on that system. Key takeaways here: we improve population health by improving our ability to execute the health production function. If we think of it as a systems engineering endeavor, the entire healthcare system executes the health production function. Famously, WHO has identified what they call the no-do gap, the difference between what are our guideline-based interventions and what we're actually doing on the ground. We want to systemically close the no-do gap. Another key takeaway: digital health infrastructure gives us a way to operationalize CQI. This is how we can do continuous quality improvement of the health system. Okay, I often refer to myself a little bit jokingly as a recovering engineer. Engineering school was 40 years ago for me, but I honestly make great use of it all the time in the health informatics work that I do. Why do we engineers need to be engaged in this important effort? And to be honest, the Sustainable Development Goals identify that by 2030, there are 130 countries in the world that between now and 2030 expect to be operationalizing universal health coverage, and they're going to need digital health infrastructure to do that. So why do we need to be engaged in this work? And there's work to do, trust me when I say it. So why do we need engineers? Well, first of all, health enterprise architecture, notwithstanding that we refer to it as architecture, is a systems engineering discipline. Point number two, to be honest, chaos wants to exert itself. There's nothing about this that's going to be self-organizing. Chaos is the status quo. We need to apply design thinking. This was already a complicated and difficult problem. If it's still a complicated and difficult problem after we've brought our best efforts to bear, then we should be ashamed of ourselves. So chaos is what it wants to be. We need to apply design thinking. That's the goal. Engineers are good at that. The other thing, this is not a theoretical exercise. Implementability is key. And I'm not on Twitter myself. I'm a bit of a Luddite that way. But the only thing I've ever said that really tracked on Twitter, I was presenting at a conference a number of years ago, and I said, what if scale was the innovation? So not only does this have to be implementable, this has to be implementable at scale. We're not going to move the dial on population health if we can't implement at scale. So I keep referring to us as engineers, but the truth is health informatics as a profession, my new profession is I am a health informatics professional. And health informaticists are actually, it's the bringing together of three key elements, the three legs on the stool. First of all, information sciences. So this is the IT and the information management aspects. That's a key part of being a health informatics professional. Then also the management sciences. Again, we get this sort of training in engineering school. The skills around project management, organizational behavior, analysis and evaluation. We're very good at these sorts of things. And then lastly, it's not just a secondary thing that it is in the health domain. We have to have an understanding of the context of the care delivery networks that we work in, and we have to understand what are the clinical workflows that we're helping to operationalize. I actually am on faculty at the University of Edinburgh. That's where I did my grad school. I'm on the board of advisors at McMaster University, near where I live here in Toronto. Their Masters in Science program in e-health is actually jointly administered by the faculties of engineering, business, and health sciences. I'm also with a colleague helping establish a health informatics school in Pakistan, and that's in its very early days, and it's going to be lit up hopefully over the coming years. Donor-funded work. I want to close with this. What attributes have made the biggest difference in my career, or so far at least? I use every day, every single day, the engineering training I got in systems thinking. That has been a huge impactor for me. I am a naturally curious person. If you're going to work in the medical field, in the healthcare domain, and if you're going to work in IT, if you aren't curious and if you aren't a lifelong learner, you're not going to succeed. So I would say that for me, my curiosity has served me greatly. I also want to tell you that you can be brilliant, and you can be one of the cleverest people that anybody's ever met. And if you can't communicate, that's just your little secret, isn't it? So I also would say that one of the things that we have seen today is that being a communicator is very important. And Eric and Axel both took very complicated things and made them completely and eminently digestible for us. I think for all of us, we should take to heart that the old joke, 4 years ago, I couldn't spell engineer and now I are one. That's not a funny joke. We have a very important role to play. Our ability to communicate is going to be crucial to that. And that's all I have. Thank you very much.
Derek, thank you very much for the third of 3 brilliant presentations. You brought a smile to my face. I can't tell you how many times I've opened plenary sessions confessing that I'm a recovering clinical engineer.